Greetings, everyone. Welcome to Bro Doc Talk. My name is Henry Lewis III. I'm a residency program coordinator and former pre-health advisor.
Hi, everyone. I'm Dr. Omar Young. I am a maternal fetal medicine specialist at the University of North Carolina at Chapel Hill, where I also serve as our associate OBGYN residency program director. Today's episode is entitled Black in Medicine, Understanding What It Means to be Black in Medicine. And today we have a special guest, Dr. Ian Molyneaux, who I will let introduce himself.
Hey guys, so my name is Ian Molyneaux. I am attending anesthesiologist and critical care physician. I am also the associate program director for the anesthesiology residency, and I am an assistant professor of anesthesiology and critical care medicine at the University of Tennessee Health Science Center in Memphis. And that's it about me. I'm very passionate about education, and I'm excited to be here.
Ian, can you tell us a little bit about how you got into medicine, how you got to where you are?
Oh boy, that is a story and a half. I'll try to truncate it. I actually did not think I was gonna go into medicine. I was good at math and science in school, and I did love biology in particular. And my story is kind of convoluted. I actually wanted to be a biochemist, actually, when I was going to college. And I actually started college at University of Pennsylvania with that idea in mind. And then 9/11 happened, and it got prohibitively expensive I'm an immigrant, so prohibitively expensive for my family to keep me in a university in a foreign country. So
where are you from?
I'm from Jamaica, the beautiful island of Jamaica.
All
and
right.
So I decided to go home, and I applied to medical school there, and I got in. And I went in with the idea of trying to see what my career would have been like if I liked it, didn't like it, because the university had a program where if you did 3 years or more, if you decided to leave medicine, which some people do, they just didn't want people to leave with nothing. Like you start medical school and you get nothing, right? And so the idea was like, okay, you can leave with a degree in what they call basic medical sciences, and then go on and take it from there. Maybe you could go work for pharmaceutical companies or whatever. And so I kind of did medicine with the idea that I was just going to try it, see how I did. And if I didn't like it, then I would take my degree and do something. And I ended up loving it. And I can't see myself doing anything else to earn a living, to be honest. So that's kind of my journey there.
That's awesome.
Thank you very much for that. So being a physician, in the US, tell us both a little bit about the experience of being a physician and then about being a Black physician. Dr. Young, we'll start with you.
Yeah, so in my experience, I am considered what's called the first generation. So I am the first person in my family to complete college, to complete a graduate degree. And so navigating the waters of medicine and medical education has been interesting, having had no benchmark for that. I will say that I've always wanted to be a physician. I've been wanting to be a physician since I was like 8 years old, where I first saw a beating heart, and I was like, that's cool. I want to do that. Had no concept of what medicine was until I actually got into college and said, this is something that I'm really passionate about and wanted to pursue. And when I think about having gone through medical school and into residency, I don't see myself having done necessarily anything else, because I think that's where my passion lies. I've always wanted to understand what we don't know, try to help those that need help, and to be of assistance or of can't find the right word, but you guys know what I mean, to the next generation of those behind me. And so that's why my interests lie in my clinical work, but also in medical education.
Yeah.
Now, to put on top of that, what does it mean to be a Black physician? I went to a medical school that was a PWI, or a predominantly white institution. And so a lot of my classmates had parents who were themselves physicians, and so had the financial resources to be in medical school,
Yep.
had the background knowledge of what it meant to go through training, and so seemed a little bit more equipped to the curriculum than those of us of color in medical school. When it came to residency, my residency was a little bit interesting in such that I was the only African American male in my residency program for the majority of my time in residency. And having predominantly white attendings and predominantly white patients was something that, in my opinion, they were not used to. And so there were many instances of both macro and microaggressions that I was confronted with. I personally hadn't have to deal with like issues of racism until being a resident. And those experiences, I think, really spurred me on into wanting to be in medical education, because I don't want those coming up after me to have to experience exactly what I went through.
Yeah.
And it also gives me clarity of perspective, such that when I have trainees, be it those of color, those who are gay, lesbian, bisexual, transgender, non-binary,
Mm-hmm.
those who have some sort of handicap, or those who are labeled as other, it gives me a better perspective and to say, this is not okay, or this is what we should actually be doing to assist this person in training,
Right.
things like that.
Right.
And so for me, I'm a little bit more cognizant of how the issues of race and what I call othering plays into not only the practice of medicine, but also how it affects those that are providing the care.
Right. I love that. That's very comprehensive. I mean, I've seen some of the challenges that you've experienced from that. I've seen how you've been able to use that to help others, in their experience. So awesome story. Dr. Molyneaux, what about you?
Questions again.
So tell us a little bit about your experience being a physician in the US, as well as being a Black physician in the US.
Wow. Yeah. So as you guys know, I am from Jamaica originally, which is a pretty racially diverse country.
Right.
And I will say that when I moved to the United States full time, outside the bubble of a college experience, the as Omar mentioned, the othering becomes a little bit more obvious, because it was not something that I had experienced my entire life, and it was a little jarring when I started first, because you were just so used to just feeling like you could ask a question, or I grew up just feeling that, okay, fine, like, if I were in class and I wanted to see something, then
Mm-hmm.
I'm like, hey, give me some room, let me see. And then when I came to the United States and I was outside of a college bubble, for instance, it was just like, you realize that, oh my God, people think that you're aggressive or you're too much, because
Mm.
and that you're looking out for yourself or your education, or just letting people know that, hey, I'm here. And they're very different attitudes towards it, and it took me a long time to get used to that. I'm probably still getting used to that, for the idea that there are days when people have their preconceived notions as to who they think should be in your shoes or your position or
Mm-hmm.
your things. And because I didn't grow up like that, I still throw it to the curve, and I still do what I feel needs to be done. One of the things that I know as being a physician of color in the United States, particularly a Black physician, especially since I work in Memphis, where my hospital takes care of a lot of underserved and underprivileged and poorly insured people who happen to be majority Black and brown, is that I've noticed, even when I was in residency, which was not a hospital that necessarily dealt with a lot of those patients, but you notice that they listen to you more. If you say, I really feel that this is the course that we should go in your treatment, they're more likely to be receptive to that. And I think it's so important because, I think the representation really matters in this regard. Like, I've had patients who were difficult with everyone else. I'll walk into the room, and then all of a sudden they're okay. They're reasonable. And then the staff will say point blank that this is the first time, he or she has ever spoken to us in a way that seems, at least that they're acknowledging what needs to happen. I'll give you an instance. Like, I had a transgender patient who let's say John to Joanna, right? So I had a female patient, John to Joanna, African American female, and I just walked into the room when she was admitted to the ICU, and I would be like, "Hey, Joanna, how you doing today? Tell me about your symptoms, etc." And then just move on. And Joanna was usually very, very, very difficult with everyone else, and she was initially difficult with me. And I just realized that every day I just went in and did my thing, and eventually she was just like, "Oh my God, Dr. Molyneaux, nice to see you again." And it was a completely different thing. And this is taking care of somebody for maybe 2-3 days, not long enough to establish any meaningful relationship, but like, they see you as somebody who looks like them, who actually cares, and it makes a world of a difference. And one of the things that
recognize that patient's humanity,
right,
and you haven't, labeled them as whatever.
A disease or
yeah, I think from my perspective that, from a maternal mortality perspective, there's good data to show that, when Black pregnant people are taken care of by Black physicians, their outcomes are actually improved. So I think
they've seen that in various specialties and even professions. So we know that to be true.
Yeah, to the point where it's like, the discussion of, protocolizing some forms of care, for instance, like the way how obstetrics and anesthesia interacts with, like, enhanced recovery after cesarean section, for instance. Like, the data has shown that if we actually stick to those protocols, like, the people of color, Black and Latino people, they do better because we're starting to do the things that needs to be done for them. But the thing is that the people who are advocating for these things are always 99% of the time, when you say that, hey, it's affecting people of color, it's people like me and Omar who we look and we're like, these are people, let's do better.
Yeah.
Because, I hate to say it, but like, I've always told people that since I've come to the United States, I've realized that medical racism exists. And it's not something that people do inherently. It's not like, a white physician goes out and says, hey, I'm going to treat Black people like crap today. They actually genuinely want to do their job. But then their motivation to tear down the systems that are causing this disparity of care, like, they don't have the same motivation that I do or that Omar does, right? Yeah. And so, and I feel that being a Black physician in this country, it makes it happen because, it's different when you see a family unit come into the ICU for me who looks like mine. Like, I'm like, that could have been, she looks like my grandma, as opposed to, okay, fine, you're seeing them as just another patient. And I'm not saying that anybody is doing anything that they're not doing, they're doing anything with malicious intent. It's just, it hits differently when you identify with it so much more.
And off of that, sorry to cut you off.
No, go ahead.
I think it's very timely that you bring that up, given the pandemic. And so I have lots of patients who have initially either not thought about vaccination or who have refused vaccination. But when I, as a physician of color, ask them and counsel them, those patients of color give second thought and give pause as to why am I not getting vaccinated and what is stopping me. And if he's gotten vaccinated and he's okay, then maybe I should get vaccinated. And I think for me, a personal success story is if I can just get patients to actually think about it.
Yeah.
I think that is a good thing. If you get vaccinated, fantastic. But I want, like Ian is saying, I want equity or equal provision of care, irrespective of what you look like, which should be medical ideal. But we all know that medical racism, implicit bias exists. And our goal, irrespective of what you look like, should be to call it out and get rid of it.
Yeah.
Right. And then, oh, yeah, go ahead.
No, go ahead.
No, but, as we talk about like things like implicit bias and et cetera, like I wanted to piggyback into the fact that both Omar and I are heavily involved in the educational aspects of providing medical care. And, one of the things that you realize is that, for me as an attending of color, like it also helps to inspire more people to say, for instance, come over to my side. I've had several medical students who'd be like, so tell me about being an anesthesiologist because I see you doing it, right?
Right.
And and then for me, I'm just like, yeah, I want more people to choose anesthesia because I think it's great. But but you can be an obstetrician and gynecologist too. It's okay.
We need us in all the specialties.
But we need doctors and in all specialties. It's not it. But I'm that also inspires me, where you'll have people who will look at you and say, hey, I want to be like you, which I never even thought as a little boy growing up in Jamaica that people would even want to be like me.
Right.
Like I didn't even think that I would have been something that people would have thought was aspirational. I always thought that I was just here trying to just get by and do good work for people to turn around like, hey, we want to be like you. It's humbling, and it's been extremely humbling, to be honest. And it just makes it so important to realize that the people of color need to be here. We need to be here for so many reasons, and that's just one of the many big aspects. And if you look at just residency programs of all specialties in the United States, I mean, like, people of color are still underrepresented, I mean, you still have a significant dearth of Black women in medicine in particular, right? And, those things we need to change those things because, if Serena Williams can be misdiagnosed for her pulmonary embolism, as a woman of and she's not just any woman, she's a woman with money, fame, capital, name recognition. And then she literally fell into the same idea of postpartum women of color not being believed when they say they have problems.
She shouldn't have to scream for a CT scan.
No, right? She should not. Like, she's a woman. You would think that she was somebody who, if she said, I'm coughing, they would have been like, let's scan her, right? And that, even for her, that didn't happen, right? Trevor Noah is suing some hospital in New York City for inappropriate care. So if you think that just because you have money, you're gonna be exempt from these things,
not at all. Not at all.
It's not at all. Like
it all starts at the beginning, right? So not only getting those kids of who are Black and brown into medicine, but also getting people actually involved in undergraduate medical education to understand how this is going to impact future practice.
Right.
Students are, they're getting more exposure to diversity, equity, and inclusion curricula in medical schools. But my fear is that there's lots of lectures, but there's not a lot of action. And
Very
so
surface.
I always say, it's all right to say that, on websites that we promote diversity, equity, and inclusion. But I always tell applicants to med schools and residencies, actually ask program directors and residents what is actually being
What does that
done.
mean? Right.
What does that mean?
Mm-hmm.
Because if they cannot give you a substantive answer, a
Mm-hmm.
meaningful answer, then that's probably not a place that you should be engaging.
I agree.
Right.
I agree.
And not only that, and I mean, like the demographics are telling. Like if you
Mm-hmm.
look at a hospital or medical center, wherever you want to go, and
Started
you
on
look at
that.
the training, and you look at the trainees, and you look at where they're coming from, you
Mm-hmm.
know, et cetera, it's very telling.
Yeah.
I was fortunate in my institution where, yeah, like Black trainees were not uncommon, right, in anesthesia, which is on the rarer side. But you will go to some hospitals where not one anesthesia resident is gonna. Maybe you'll have one out of 30
Right.
who is a minority of some sort, and that's normal for them. And
Mm-hmm.
Omar and I know for a fact that that's not okay, because there are plenty of very well qualified applicants of color
Yeah.
who just need a chance.
Yeah. Yeah.
Just need a chance. And it's just the way how
Mm-hmm.
the whole process is made to prop up the people who have the means to make it.
Right.
Mhm.
I love this conversation overall because I feel like it gives more depth to the conversation about DEI. I feel like I hear that term thrown around in academic medicine and academia all the time in general, but it's, as you were saying, Dr. Young, it's just very surface. There's
Mhm.
no action, and then oftentimes we don't know what the action is. I mean, you all
Mhm.
gave one of the best examples, which was the patient experience, and that's a piece of DEI in academic medicine I never hear about. And
Mhm.
to me, as a patient, as someone who works in academic medicine, but also a patient in the healthcare system, that's most important to me.
Mhm.
I want to see as a patient a physician who looks like me and a physician that I can relate to. So when we
Mhm.
talk about diversifying the medical field or whatever field we're talking about, we need to be focusing on the customer, the patient, who we're actually impacting with this diversity.
Mhm.
So that I feel like that's the conversation I want to hear more often in this whole DEI in medicine. So thank you for those examples. I love that.
You're welcome.
Yeah. So moving on to another topic, I mean, you all are very accomplished in your fields, and we know it takes a village. So let's talk a little bit about mentorship. We'll start with Dr. Young. Tell us a little bit about your experience with mentorship in medicine, and also just the importance of mentorship, especially as a Black physician.
Yeah, so I think mentorship is important throughout the entirety of your career, not just when you're in training. And it's important to define exactly what is a mentor. So for me, a mentor is someone in which you can have a give and take, equal exchange relationship. Someone that is going to not give you lip service, someone that's going to, encourage you to think outside of the box, think of things that you may not have thought about that you're even capable of,
Mm-hmm.
someone that can push you to the extent of which you're capable. For me, I had a great mentor, particularly in my fellowship, that I continue to talk to this day, who is one of the models of medical education that I use. And she and I have engaged in some education scholarship over the years, and I can talk to her freely about issues that we have with residents and medical students, and I consider her a lifelong friend. And so I think that is an example of mentorship. I also have people in my academic life who I go to just for advice, not necessarily related to, clinical medicine or to medical education, but someone on how to navigate the waters of academic medicine. Um, I myself am a mentor to students who are looking to, take my job one day. And I welcome that because I want people to, essentially be fully informed into what they're committing themselves to. But also I want to see exactly what you're capable of and can I make you do better? And I think that is a symbol of what a good mentor is.
Yeah.
Hmm.
Yeah, I love it.
Awesome.
Yeah, yeah. Go ahead.
Well,
Yeah.
yeah, as far as mentorship was for me, I mean, I don't know if I think I just lucked out, to be honest. I mean, the people that I had around me through my intern year, my residency, and fellowship, uh, they were phenomenal. And these were
Mhm.
people they were just dedicated to medical education, and they inspired me as well. I mean, I could just pull any one of the attendings I worked with when I was in an intern, a resident, particularly in fellowship, who they were all mentors. Like I used to tell people most of the docs I worked with, if I could have been a quarter as good as them, I knew I would have been a phenomenal physician.
Mhm.
Of course, a couple of people stood out in my mind. Particularly my faculty advisor when I was in residency, who was also one of the few people of color in the department, and he understood the challenges that I had or would experience, and I felt lucky that he was somebody I could go to. Like his first thing was to take you out to dinner. Which as a broke resident was wonderful to go to a very nice high-end
I'm sure.
restaurant. And then as a new yeah, and as you progress in your residency, and then somebody junior comes in, and then he gets assigned to them too, you're just like, you get a little jealous. But he was somebody who would, I would say, he would slap you on the wrist when it was needed. He would give you a shove in the right direction when it was needed. He was somebody you could go to the vent.
Mhm.
And he always had my best interest in his mind, and he was just a reflection of the culture I was in at the time, which I was very fortunate in residency to have. It's not something that I know was typical, because a lot of people that I speak to is like, yeah, our residency was not like that, and definitely their fellowships were not like that.
Mhm.
um and so, like, it's the behavior I try to model as well, where I try to let my residents know that I'm going to push you because this is what you need to develop, and I will slap you on the wrist when you do something wrong, and I will push you in the right direction when the time comes. So um I can only say that, as far as mentors and mentorships are concerned, like, I look back at the whole situation and I'm like, I was really fortunate. You're right, it takes a village. And, we just have to continue to model that kind of behavior as well, where it's just like, you need to let them know when they're doing well, encourage them to do good things, let them know when they're doing not great things, when to step back and reevaluate, and be cognizant of the issues that they may be having. Because my mentor would be point blank, would be like, yeah, I know how hard it is to be rounding in the ICU, and you're the only person of color right there. I get how you may feel like that, but you just go do your job, and then you tell me about anything that may be happening. A lot of people don't have that kind of that kind of reassurance, where it's just like, I know you may feel something, because I will tell you this. I said this to a friend of mine once, who told me point blank, why do you see everything in color? Like, you're just another doctor there. And I'm just like, I stopped having a conversation with him because I realized you don't get it, and that's
Yeah.
okay. That well, it's not okay, but, like, I knew for me what that meant. But when I said it to my mentor, who was also a person of color, he totally got the fact that, yeah, you feel a little out of place, it makes you second guess. Should I open my mouth? If I make a mistake, how is it gonna be received, etc.? It's not, you don't have the same, you don't feel that same safety net that other people feel.
Mhm.
And it's always nice to have somebody in your corner who gets that.
You make an interesting couple points. So the safety issue, not that we're saying like, you need to be around people of color to feel totally safe,
Right.
but you feel, I guess I would use the word, less criticized
Mhm.
immediately or more comfortable.
Comfortable,
And
yeah.
then it makes you hyper vigilant, right? Because
Exactly. And so, like, when I was a resident, I would get evaluations where I was perceived as unprofessional or aggressive
oh yeah.
or loud or different little coded buzzwords that a lot of people of color understand exactly what that means.
Mhm.
Because if someone else who didn't look like me acted the same way that I did, they would not get the same evaluations, right?
100%, Omar. I can't tell you the amount of times where, I've said something and it's been perceived as aggressive or condescending or whatever. And then you
Mhm.
hear someone else, because I work in anesthesiology. So I work with a lot of surgeons, and then you'd hear surgeons like literally use curse words and literally like throw things. And I'm like, so why isn't he being written up?
Mm-hmm. Mm-hmm. So I've been on both sides of the issue. So I totally see what you're saying. It is very interesting, particularly when you are working with a team that's led by a person of color, when you are that person, a person of color, as
Mhm.
opposed to I would say a racially discordant team. You may have like a great experience on both teams, and that's great. But there's something to be said about essentially the magic of working with someone who understands the experience where you're coming from. And when you're a trainee or an attending of color and things like, racial things happen, sometimes we have a tendency to feel like, am I the crazy one?
Mhm.
And did I do something wrong?
Right.
Whereas if you have someone around you in situations like that that understand where you're coming from, you actually are like, oh no, I'm not crazy. It's the world that is setting me up for
Mhm.
failure.
Now,
Yeah.
I have a question for both of you, based on that. Have you all had an experience where you worked closely with another Black physician and that experience did not go so well? It wasn't oh, we relate to each other, we're helping each other out. It was, maybe competition or a lot of butting heads, because that often happens in many work settings. Have you ever
Mhm.
had any of those experiences?
I have been as an attending, I have been in practices where I've dealt with a physician of color that the interaction did not go, um, what's the word I'm looking for? As professionally as I would like it to go.
Mhm, mhm.
Um, my point is that I don't think that you have to be working with a person of color, um, and race doesn't, end. We're not all gonna like each other, and we're
Right,
human,
right,
and
right.
that's
Just
fine.
because of our race, right.
Exactly. But
Well, I'm sorry, I have not had that issue. Usually,
Well,
and
that's
maybe it's
good.
because no, because maybe because in anesthesiology there's not a lot of us, so it's usually like, oh my God, yes, we're
A Black physician, yeah.
yeah, it's like in my field, it's just like when you see another one, we're like freaking unicorns.
Yeah, yeah,
Like when we see another one of us, we are like, I don't know. I think we're duty bound to make it work, because
right,
you can't alienate the one other person that looks like you.
right. No,
So
that's great.
I personally have not had that. I am sure it happens, but
Mhm.
like I think we may make a concerted effort to just be give each other the nod, like, hey, what's up, man? Or you'd be like, oh my God, like another one. I
And
mean,
work well together. Yeah.
yeah.
Yeah. I mean, I only ask because I think oftentimes, when it's just very few of us, sometimes, certain certain ones of us will feel like, oh, well, I have to be the best one, the best Black professional in this, so I'm going to create this competition, and
There's no
I really want. I'm sorry.
Yeah, I was going to say there's no need for competition. There's
Right.
space for everyone. Everyone has their own,
Right.
unique strengths, and so I think
Right.
people just need to, calm down.
Yeah.
Yeah,
I agree. I agree with you.
I personally have not had that experience, and I personally would not think that way because, as Omar said, not only is there enough space for us, but like our patients only do better when we work together. And
Right.
a lot of people sometimes in medicine forget that when they're doing a lot of things, and you have to remind them, you need to take it back to the people that we're supposed to be looking at, right?
Exactly.
And when you do that, a lot of the times, a lot of the nonsense starts to go away when you realize, oh, this is not productive in any regard because we got a patient to go look after. We got family to go look after. So, squash that nonsense and be professional, be collaborative, do your job.
Right.
And whenever,
I think a lot of that stems also from, particularly, maybe it's I'm don't have data necessarily to back this up, but could it be an insecurity amongst those of color who say, like, I have to act in a certain way and carry myself as like the most knowledgeable person and this, like, quote unquote badass of medicine.
Right.
When you come to someone else for advice and you may not necessarily agree with them or don't understand what they're saying, but you confront them with a certain attitude, I think that is what can, sour a professional relationship, particularly amongst physicians of color. When Henry, you were speaking of that, competition. But I think if, particularly a physician of color, understand that, we all are extremely lucky to be in the position that we are.
That's right.
And our ultimate goal should be to take care of the patients that we signed up to take care of. And if we make that the central goal, then everyone is going to come out happy.
Amen.
And yeah, because I will say this, like, whenever I find that there's a lot of interprofessional animosity or whatever, and then you start reminding people, like, okay, fine, like, would you like, if this were your mom, would you like people to be behaving like this and not come into a consensus, or trying to force something through because, I don't know, you want to go home at 3 o'clock? Like, is this what you want? And to be honest, the reasonable people are gonna come back like, okay, let's fix this. I mean, like, just like with any profession, like, you're gonna have a full string of personalities, for instance. So some people are gonna be very dedicated and conscientious, and some people don't care. I mean, it's the nature, and it's one thing that I think people find jarring about just health professionals on a whole, not just physicians, but nursing, whatever you take, that people have personalities, people have a different moral compass or whatever. We expect everyone to be, to have like a basic, understanding of these are the things that you're supposed to do. But, newsflash, you will have a 1% of people who are not going to be as good as we'd like, or not going to be as caring as they should. And, we do our best to, as I said, we do the training and whatever, but like, I hate to say it, people are people, and not everybody is supposed to be in medicine, but yet some of them are.
So moving on to our final question, let's talk a little bit about bias in the recruitment process. I think we all have experience with this. So what are some issues of bias you've observed in the recruitment process, maybe from your own experience as an applicant or as a faculty member? And
Ian,
Dr. Young, start.
I was going to offer Ian to go first.
Oh, yeah, that's fine.
I want to go first.
Sure. I think, first of all, I think understanding that race and racism are two totally different things. So race is, physical characteristics that have been assigned a certain value by society, whereas racism is the economic, psychosocial,
That makes
health impacts of that assignment. And one of the things that I think has evolved over the years that I've been involved in medical education or in medicine in general is when we get applications. And now what we do in my program is we don't look at pictures when we're going through the applications initially. And so you're basically evaluated on the merits of your application, which I think are great. Because we all carry inherent biases, and it's how we actually survive in the world is to our brains make snap judgments. The problem is that sometimes when people see a certain images, they may make judgments that are not necessarily correlated with what is at hand, right?
Mhm.
So I think that has been one mitigating factor or factor that has allowed us to try to eliminate certain amount of biases in our recruitment process.
Yeah.
I think the other thing that nationally that can be done to mitigate bias is to educate those that are actually interviewing or administrating a residency program or a fellowship program or a medical school um, on what it actually means to have people of color in your programs. Um, for example, getting faculty to have intentionality in their language, getting faculty and students to understand the role that race and racism play into not only like patient care, but the actual medicine that you are practicing. So I can speak from a high risk obstetric standpoint. We have something called a VBAC calculator or a vaginal birth after cesarean calculator that for many years involved variables such as height, weight, have you had a previous C-section before, things like that, but also put in there, were you Black or not? And in the last year or so, we've come to understand that, why was that in the initial calculator in the first place? Because that actually isn't a medical thing. It's something that has happened because of the evolution of racism over the last few hundred years. And so we've removed that from our national calculator to more accurately give women what their risk of or chance of success of having a vaginal birth after C-section is. In the old calculator, if you were Black, your chances were lowered and such that Black women were at a higher risk of having a C-section. And so that just significantly increases the morbidity and mortality in that population. And so I think those are things that can help us in medical education. So when I say intentionality, I think we need people to actually be mindful that a problem exists, and B, you are dedicated to actually tackling the issue at hand. And C, when you have people of color in your programs, offering them or being able to provide them with the support that will set them up for success.
I love that you mentioned intentionality, and I feel like there are a lot of programs out there, whether it's at the undergraduate medical education level or graduate medical education level, where there aren't any faculty or administrators who will have that type of intention. So in those situations, what do we do?
Oh, me or yeah.
I
No,
mean,
you left
any
it
of
up there,
us.
but like it's. I mean, that's a very tough question to answer
Yeah.
because, say, for instance, for me, I'm in the South, for instance, right? So and where I am covers Mississippi and West Tennessee, Arkansas, Missouri, Kentucky, etc. Right? Like I'm not in the most liberal of areas in this country. And you will come across some people, even in medicine, with some very, very, archaic and sometimes very racist views on how they view things. And not necessarily, again, some of it is not, the majority of it is not malicious, but as Omar said, it's the intentionality that needs to be addressed, where it's just like, okay, fine, where you think that this doesn't matter, it actually matters, and matters a lot, right? And so for the whole thing about how do we mitigate this or whatever, I have been a strong proponent of your program should look like the people you take care of. That's really it. If you are in a area where 50% of your population is African American and 25% of them are Latino, etc., I think your program and your hospital system should somehow try to look like that, because that means that you actually are part of you're the community.
The community,
Right?
right.
You are the community. Like if everybody in your place is, majority African American, Latino, Asian, or whatever, and everyone is white, we have a problem. And that conversation needs to be addressed, because
Mhm.
and this is not just a medicine thing. This is sometimes just the power structure of the United States at time, where it's just like
Mhm.
the people in power don't look like the people that live here.
Right.
People who are in charge do not
Making the
understand the
decisions.
struggles of the people that they're supposed to be leading or helping or dealing with.
Right.
And I think that's probably the number one thing that needs to happen, where you know, people from the community, and not only that, and where are the people who are actually in the community, who are coming to our programs, who is invested? I will give my university credit where they say point blank, like, if you are from Memphis or from Tennessee, you are prioritized because you have a vested interest in not only matching here, but staying, becoming an attending, contributing to the medical knowledge and research that happens in this area.
Mhm.
And I give them credit for saying, hey, we want the people in our community to come here, grow here, and develop here.
Mhm.
And that is, as Omar says, that's an intentional thing, right? As opposed to people, because I've always disliked this idea where people say, oh, I just want the best applicants and I don't care. I don't care. That has always irked me the wrong way,
That's a
because
very
like
small piece of the formula.
it's
It's a
not
very,
only
very
the
small piece.
small piece of the formula, like who is determining that you are the best
Right,
applicants? Like,
right.
right?
It's relative.
Like what are we using to say that you are the best applicants?
Mhm.
Because maybe I'll get into trouble for saying this, or maybe I'm not, but like if you have a person of color coming from an underprivileged area who is scoring the same as a white kid from suburbia, believe me, that person of color has gone through a lot more just to get that same score, right? And so I will tell you that that person is probably way more qualified just
Mhm.
on that instance alone. And like people just want to use raw numbers or raw metrics, and it's a lot more nuanced than that. And
Mhm.
if you had said, if you take that same kid out of an underprivileged area and put them in an area where they never had to worry about housing or food or whatever, they probably would have scored even better. uh,
Mhm.
we
Mhm.
don't know. And
So,
so
oh, sorry, go ahead.
no. And so the idea is that, are we intentionally making an effort to not just say, hey, we want applicants, but making sure that we choose a diverse pool of qualified applicants? Then that may be the issue, who are part of the community, who look like our community, who want to be a part of the community. That may be the way forward. Or maybe I'm talking nonsense. I don't know. But I think it's definitely worth the shot.
And
Mhm.
particularly since in 2022 now, USMLE is pass fail.
Right,
Correct.
And so residency programs and, to an extent, fellowship programs need to have a more holistic approach into evaluating
right.
who they, number one, are going to interview and who are they going to be ranking in their programs. And so I
Mhm.
think Ian is totally right. And, understanding like when we did have scores, like, very historically, persons of color would score lower on the standardized exams as compared to white colleagues for a variety of reasons, which could be another episode. But I think now that we've eliminated the the excuse of or the vetting process of scoring, we actually have to now read people's applications and understand where they're coming from and decide exactly what kind of program do we want to be, right? So I think it's going to be very interesting in the next cycle, particularly for residency programs, to say exactly,
what are they looking for?
Exactly, what class are you going to build?
Yeah, because it's just like you can't just automatically filter people out because of they didn't meet a minimum score for your
not anymore.
That is now being eliminated. However, the only caution that we've all had for that is, unfortunately, for some people, the scores do correlate with passing your boards. So, and that's how some of them are justifying it. But again, I feel that any program that is worth their salt works with the people they have to make sure you have a board exam to pass, and we're going to make sure that happens for you, right? And so again, it's got to be important to look at these applications holistically and decide where do we go from here. And it's going to be an interesting and exciting time going forward, and I can't wait to see it happening.
Right. So along with the point that USMLE is going to be pass-fail, what are some things you think applicants can do to, help themselves out in this recruitment process?
I'd like to start with the things not to do, and then Omar can say,
please, yes.
Yeah, because like I have seen some things in applications that would make sailors blush, right? I mean, I personally, I love, like, people tend to skim certain parts of the applications, and then you'll have like people in my program where we tear it apart with a fine-tooth comb, right? And my favorite thing to look through is a personal statement. Like, personal statement says a lot about you, even though it's just one page, right? Because it should take you time knowing that I have one page to tell people about myself and why I want to do this specialty.
Right.
And why I want to go to your program and why I am a good fit for your program. You have a lot to pack into that, right?
Right.
So it should take you time. It should not be something that is just written on the fly. And then for me in anesthesia, like, there's certain things that people say all the time where I like the pharmacology and the physiology and whatever. Like, we hear that all the time, to the point where you talk to most anesthesia interviewers or residents, and we just, like, if we hear anatomy and physiology or pharmacology one more time, we want to throw our hair, we want to jump out of a window, right? But it's what people think that we want to hear. And, we don't want to hear that. We want to hear about, why do you think you can fit in? Why do you think our program is a good fit? What do you have to contribute? The important things about yourself that you want us to know. And, basically why you like our specialty. Those are the important things to answer in your personal statement. And, like, people will say all sorts of things sometimes that make you very concerned. Like, they will say things like, I was a medical student in the ICU, and they asked me to do the procedures because I was the best. And, it makes you wonder, like, okay, so you as a third or fourth year medical student were being asked to do things because the attending or fellow who's been doing this for a number of years before you was somehow not good. They were somehow not good enough. That does not compute. And those things just, like, we will read those things and then automatically put, like, do not rank this person, right? Like, and then some, and these people wonder why, like, I have good scores and whatever. It's just like, yeah, but, like, you come across as a very arrogant person that nobody wants to work with, right? When I read your application, I should be reading it with the sense of, okay, this is a guy or girl or non-binary person who wants to come to my program and has something to offer and wants to be taught, right? Because at the end of the day, you're still a baby in whatever specialty you have, and you should be coming up So it's like, okay, I want to be a sponge. Teach me, right?
Mhm.
Hopefully you'll be even better than me when you're done. I mean, that's the goal, right? Not just to be good, but hopefully you're even better. And if you're already better than me, then why should I have you
Right.
here, right?
Right.
So that's one of the big things I think that a lot of people don't realize, that make people just like, meh, I don't want to deal with this one, right?
Mhm. Mhm.
Another thing that I caution people on is be careful, like, if you are applying to, say, for instance, OBGYN, and that's where your heart is, right? You really want to do that, then, and you're applying to family medicine as a quote unquote backup, right? Don't do something nonsensical like apply to the same two programs in the same hospital system. And people do that. Like, I'm sorry, like, people do things like that, and then the thing is that the programs are going to talk to each other, and they're going to be like, okay, then does he or she or they want to do OBGYN? Do they want to do family medicine? What are their goals, right? That should not be something that people are discussing about your application, because the average application in residency, regardless of how popular a specialty is, it's usually at least 500 to 700 applicants, sometimes 1,000 per spot, right? You know this, right? And so you have to make your application at least be reasonable in those regards. And those red flags are there. And stay away from the red flags, I would say, by all things. So at least your application gets to the second portion,
Mhm.
right?
Yeah, I think jumping off of what Ian was saying, um, when you're going into the application process, I think it behooves you to have, again, a good mentor, someone that, can read your personal statement and, tell you what is right, wrong, what have you, someone that can go over the types of programs that you're applying to, the number of programs that you're applying to, someone that can act as an advocate for you if you identify a program that, is like your number one choice. Someone that, will identify for you or help you to say, is this going to be a good person to write a letter for me of recommendation or not? And we've talked about this in previous episodes, someone that, can help you with practice interviewing, right?
Mhm.
Because when you come to me, myself as an associate program director, I've looked at your application already. And
Mm-hmm.
so everyone that I interview, I've already assumed, and I tell other faculty that are helping me interview, I tell them, assume that the candidate has been academically vetted and they're great. The interview is for me to say, do I want to be up with you at 3 a.m. doing a C-section?
Right.
Or
It's the
are
personal part.
right,
It's
or
not even that. It's just like it literally is. When we do these interviews, it's more like, okay, are you just a normal person that can function around other people? Because
Mhm.
as much as we academically vet all these applications and like look at this holistically, like nothing beats me having a face-to-face conversation with someone or a virtual conversation with someone.
Mhm,
And you realize that some people are not what they come across on the paper applications at all. And it's not to say that we're being biased about it, but like um, I remember I was actually helping with fellowship interviews once for critical care. And, I asked an applicant, like, what is your favorite thing about critical care? And I don't know if it's that she got stumped or whatever, but like she had nothing to say. And it just, it makes you wonder. I'm like, okay, fine. Like, then why are you here? Because
Mhm.
everything else in your application looked great. But then speaking to you, it's just like, you know, I didn't know what to make of her, you know?
mhm, mhm. I agree. Um, yeah, that's do not come into an interview not
Mhm.
knowing your application or not having the
Right.
agenda of trying to get the job, right?
Mm,
Right.
Essentially what you're doing.
yeah.
And the other thing I would say is don't come into an interview without having done a little bit of homework. Like,
Mm,
you shouldn't ask questions about like, how many residents are there or what type of rotations you are. Those should be questions that you already know the answer to.
Mm-hmm.
Get those nitty-gritty questions of what is the culture of the institution? What's your mission statement? Or what do you see as the trajectory for the department in the next like 3 to 5 years? Those are legitimate questions
Mm-hmm.
that any applicant should be asking. And I think particularly for persons of color who may not have ever been in a professional environment before or understand how, the ins and outs of medical education, having someone that has experienced this before and using that knowledge is super critical.
Mm-hmm.
Right. And I want to just piggyback what Omar says is that you really do need to practice a little bit about your interviews, and it's not because you're doing it because you want to put up a facade, but it is nerve-wracking to be in that situation, even if it's virtual, right? Like, especially when it's the place that you really want to go to, right? I guess one of the things I would say if you interview at most places is that the people are just trying to get to know you, as an applicant. They've already said that you clearly have the chops to be here. They want to see how you are. Like, I remember in my residency interview, one of them, we ended up talking about biking, right? Because I had mentioned that as one of my hobbies. And I spoke to them about, what it was like for training and, possibly entering a race when I was much, much younger.
Mm-hmm.
And whatever. I just spoke like I was just speaking to someone and letting them get to know me. And I ended up matching at that very institution and I chose that place in particular because it's as an interviewee, you're also trying to make sure that place is a fit for you too, right? And so you should not be uncomfortable asking questions that are appropriate and relevant. That does not make you seem like you don't know anything about the place. Like you say, oh yeah, this hospital, how many beds are in this hospital? Like, come on, man, you should know that already. Like, you want to come here, right? But you could ask questions like, what do you think some of the challenges that you think some of the residents may face with meeting case numbers, and how would I mitigate that when I'm here? Or if I rotated here or I were a resident here, like, how would I mitigate that? How do you think I would go about doing those things? And that shows that not only do you have interest in coming to this program, you understand that no program is perfect, and that you want to function and thrive there anyways, right? Those are the things that I would say that those things look great, as opposed to, so do you guys, like for me in anesthesia, so do you guys do acute pain at this place, or it's just like, oh my God, so that's all I have to say about that.
Yeah. All right. Thank you, both of you. This was an excellent, comprehensive discussion about really what it means to be Black in medicine. And, we learned a lot about mentorship, the importance of professionalism and really utilizing your resources in your community to help you be successful in this profession. So thank you all for tuning in, and stay tuned for another episode of Grow Doc Talk. All right. Bye-bye.